I want to talk about fully reversible interventions, and again, I've got a little asterisk there because puberty blockers. I think we've been seeing it wrong for a number of years. Puberty blockers are 100% reversible in terms of stopping puberty, and when you stop those blockers, puberty comes right back on. So I think that that's fair to say those are fully reversible, but there are some effects on the bones, which I'm only going to just briefly talk about, which may not be fully reversible. And I think when we're talking about starting a kid on a therapy, what I tell the parents is, it's like any medical therapy, there's going to be some risk and there's going to be benefits. And when kids are like really struggling, maybe the price we're going to have to pay is a bone mineral density that's a little bit lower than what we would like. You probably know that we don't start puberty blockers until a person's in puberty, 10 or 2. This is sort of done historically because we don't have a blood test. We don't have a brain scan that tells us the kids who are really trans. And what we know is that many kids who sort of cross-identify pre-pubertally, most kids start to solidify their gender identity around the time of puberty, if they haven't already done it before that. And that this is really the time where it's a little bit easier to make sure that we are kind of weeding out those kids who really are not going to follow a sort of a traditional trans journey. They may be kids who end up being completely cis and straight. They may be gay. They may be cross-dressers. But this is kind of the one way we have of separating the really trans kids from those who don't really need medical therapy or don't identify as trans. Now, we have to remember that if you're an assigned female, assigned females can go into puberty at age 9. And this is maybe where we have to start treatment with blockers. And that's awfully early before we would consider like transitioning them to hormones and things like that. So some of these kids may be on treatment for quite a long time, which is a little bit uncomfortable. Well, there's lots of benefits, though, we know from the blockers, right? We know that just stopping the pubertal development is hugely a relief for kids. It does slow down their linear growth, and it slows down sort of some of the bony changes of puberty, the sort of bigger jaws in the assigned males and the broader shoulders versus the sort of wider hips in assigned females. It stops androgen-dependent hair growth, so we don't have to then worry about kids requiring electrolysis or laser down the road. A huge source of dysphoria for the trans feminine kids is having a deeper voice or a big Adam's apple, and we can prevent that from happening. Chest growth in boys is also a major source of dysphoria. Lots of the trans feminine kids really don't like the fact that they're having erections or wet dreams or things like that. I think menstruation, having periods, is probably the major source of dysphoria next to chest growth for the boys, and the whole possibility of fertility. These can be all very dysphoria causing, and as well libido. So we can decrease all of that with the use of blockers. But there are some side effects, and again, I don't have a lot of time to talk about them. But one thing to know is that puberty blockers initially work by making puberty happen faster for the first couple of weeks. So we have to warn kids that, in fact, they may notice a little bit more breast growth. They may notice the first period happening. The trans feminine kids may get more erections. But within a few weeks, then the medications kick in and the gonadal steroid hormones go to 0. We do have about a 5% risk of having a local reaction. These kind of look like aseptic abscesses, sterile abscesses. And so that can sometimes lead to problems in having to discontinue the medications. As I mentioned, it can elicit the first period in an assigned female. One of the issues that we've known about for a long time is that if we were to take the assigned males and start them on blockers as soon as they go into puberty, that leaves them with not very much genital tissue. And then down the road, if they're thinking about a vaginoplasty, then there's not as much tissue to work with. So in the assigned males, we actually try to hold off a little bit on starting blockers so that they can get a bit of genital growth, but usually at some point the voice starts to get deeper and the kids just get too uncomfortable, and then we kind of throw in the towel and start blockers there. With the assigned females, we generally tend to start as soon as they get some breast growth. Some very rare side effects from the blockers: benign intracranial hypertension, probably 1 in 1,000, 1 in 10,000. Prolonged QT interval with some of the psych meds or any other medication that can cause that. Again, probably more of a theoretical risk on the order of 1 in 1,000, 1 in 10,000. There are some effects on bone, which I will talk about, and there has been some raised concerns about whether or not we're having an effect on brain and cognition. I think having gender dysphoria is also not good for your brain, and so I think even if we do find that there's something going on there with cognition and the blockers, that I think we have to also balance what would happen to these kids' brains if they continue to suffer. Just briefly, the analogs, when we halt puberty, we halt bone mineral accretion, and that's a really important part of puberty. When we start back on hormones, then the mineral accretion picks up. We do know that the trans feminine kids, interestingly, have low bone mineral densities even before you meet them. And people don't 100% understand this, but it's seen in kids and in adults. And it may be due to the fact that these kids perhaps are not comfortable being out and about and active and doing sports when they really don't feel like their body is going to match that of their cisgender female friends. When we've looked at longer term studies of bone mineral density in kids that treated for at least 5 years and then on hormones, we found that things have recovered pretty much completely for the boys, but the girls have not completely recovered. Their bone mineral densities tend to be low, and we don't know if that's, we really understand it well. We do know that estrogen therapy has probably been a little bit too conservative, I think, for girls, and I think we are getting a bit more aggressive with using higher doses of estrogen quicker. But for all kids, we stress very strongly the optimizing calcium and vitamin D intake and trying to keep active in whatever way they can do that involves, bouncing on the ground and making your bones stronger. Well, do the blockers actually do anything for our mental health? And this is one cross-sectional survey. There's a number of studies. I'm just going to show you a few. This is a cross-sectional survey of 20,000 trans adults in the age group of 18 to 36 years. And of those, all of those people, 2.5% had received pubertal suppression. And when you look at that 2.5% versus the other 97.5%, that the adjusted odds ratio of suicidal ideation, for instance, was about a third. And it was, definitely much lower than those kids who hadn't been offered pubertal suppression. Now, it might not be the blockers, of course. It might be those parents who got their kids help earlier, so they still qualified for suppression. But in fact, it does seem to have an effect having gotten early treatment with blockers. The other complaint that you'll hear a lot is, well, you put them on blockers and they're going on hormones, and then there's like on this train that won't stop moving, and then all of a sudden they have to have surgery. And this is one of a couple of studies that shows that not everybody that goes on blockers goes on hormones, and that's exactly what we want. We are using blockers not just to put, just to halt time until we're okay with using hormones. We want the kids to have time to explore their gender, where their journey is taking them, without having to worry that their body keeps changing and the sort of the pressures that they get from a body that they are increasingly unhappy with. And so I think it's really important to remember that not everybody that starts blockers is going to go on hormones, and that's a good thing. That's not a detransition. That's a kid figuring out where they want to be. That's a success story.